Bismillah ar-Rahman ar-Rahim. Today we will discuss leukemia. Leukemia is the most common neoplasm in childhood. It represents about 41% of all malignancies less than 15 years of age. Genetic and environmental factors predispose to childhood malignancies. Genetic factors include identical twins, Down syndrome, Fanconi anemia, etc. Environmental factors include ionizing radiation, drugs, alkylating agents, benzene, advanced maternal age, Epstein-Barr virus, etc. Types of leukemia. First, acute lymphoblastic leukemia, representing 77% of the total. Second, acute myelogenous leukemia, representing 11%. Chronic myelogenous leukemia, 2 to 3%. Juvenile chronic myelogenous leukemia, 1 to 2%, and undefined leukemia, 7 to 9%. Now we'll talk about the most common type of leukemia, which is acute lymphoblastic leukemia. It is the most common type of childhood leukemia, representing 77% of the total. Sex incidence is male to female equal to 1 to 2 to 1. Clinical presentation. The initial presentations are usually non-specific as anorexia, fatigue, irritability, and intermittent low-grade fever. There may be bone or joint pain, especially in lower extremities. Bone marrow infiltrations with blast cells and subsequent failure of hematopoiesis can lead to anemia, presenting as pallor, tiredness, headache, dizziness, thrombocytopenia, presenting as bruising, bleeding, retinal hemorrhage, neutropenia, presenting as pyrexia, and repeated infection. Organic infiltrations can present as lymphadenopathy and hepatosplenomegaly. There may be bone tenderness and joint swelling. Rarely there is increased intracranial pressure leading to papilledema, retinal hemorrhage, cranial nerve palsies. There may be respiratory distress, usually due to anemia, but may be due to large mediastinal mass. There may be skin infiltrates, especially in infants, and there may be testicular infiltration, which is rare at presentation. The diagnosis of leukemia. Anemia and thrombocytopenia are seen in most patients. Leukemic cells are often not observed in the routine peripheral blood film. Most patients with acute lymphoblastic leukemia present with total white VC count of less than 10,000 per microliter. White VC count may be normal, increased, or decreased. The leukemic cells are often initially reported to be atypical lymphocytes, which need further evaluation. There may be no blast cells on blood film, what we call aleukemic leukemia. Bone marrow examination. Leukemia is diagnosed when the homogeneous population of lymphoblasts representing more than 25% of bone marrow cells. Regarding morphology, blast cells are classified according to the French, American, British FAB classification into L1, 80 to 85%, L2, 10 to 15%, L3, 2 to 3%. According to cytochemistry, special stain which distinguish acute lymphoblastic leukemia and acute myelogenous leukemia. Immunophenotypes, when there is monoclonal antibodies, differentiate cells of lymphoid or myeloid origin or subtypes of lymphoid origin. According to the cytogenetics, number of chromosomes and structural changes, that is translocations and chromosomal abnormalities, which are found in most patients with acute lymphoblastic leukemia. Other investigations include lumbar puncture to assess cell counts and blood cell, biochemistry like blood urea, electrolytes, liver functions tests, and immunoglobulins, viral serology, baseline chickenpox and measles status, etc., radiology, chest X-ray to seek for mediastinal mass and pleural effusion, abdominal ultrasound for organomegaly and abdominal masses. Differential diagnosis of leukemia include acute myelogenous leukemia, neuroblastoma, rhabdomyosarcoma, Ewing sarcoma, retinoblastoma. Causes of primary bone marrow failure like aplastic anemia, myelofibrosis, ITP, neutropenia, infectious mononucleosis when there is fever and lymphadenopathy, rheumatoid arthritis when there is fever and joint swelling. Treatment of acute lymphoblastic leukemia. The single most important diagnostic factor in acute lymphoblastic leukemia is the treatment. This includes first, supportive therapy by IV hydration plus allopurinol before starting treatment, RBCs and platelet transfusion, antibiotics for febrile neutropenia. Chemotherapy, there are several phases. First, what we call remission induction or induction of remission to eradicate the disease from the bone marrow, usually for 4 weeks, using a combination of vincristine plus corticosteroid as dexamethasone or prednisone plus asparaginase plus minus intrathecal cytarabine or methotrexate plus minus daunorubicin. This leads to 98% remission. Second, CNS therapy to decrease risk of CNS relapses as intrathecal methotrexate, intensive systemic chemotherapy, and cranial radiation only for CNS leukemia. Third, intensification or consolidation therapy, a combination therapy to prevent drug resistance for 14 to 28 weeks. Fourth is maintenance therapy for 2 to 3 years as daily 6 mercaptopurine plus weekly methotrexate plus 4 weekly vincristine and dexamethasone. Cotrimoxazole is given during therapy as a prophylaxis against pneumocystic cardiac pneumonia. Bone marrow transplantation for small number of patients with particularly poor prognosis, especially those with Philadelphia chromosome when there is translocation between 9 to 22 chromosome. Now we will speak about relapse. It is a major impediment to the successful outcome. First, bone marrow relapse, 15 to 20%, which is the most serious complication. Second, CNS relapse, and the third one is testicular relapse, representing 1 to 2% in boys. The prognosis of acute lymphoblastic leukemia. Most children with acute lymphoblastic leukemia can be expected to have a long-term survival with a rate of more than 80% after 5 years of age. So it has a good prognosis. Less favorable factors include age, less than 1 year or more than 10 years at the time of diagnosis. Second, white VC count more than 100,000 per microliter at the time of diagnosis. Third, slow response to initial therapy. Chromosomal abnormalities including hypodiploidy and Philadelphia chromosome, and other parameters to assess prognosis as immunophenotype and cytogenesis. Thank you very much for your listening.